So the session will start short.
Hello. Good afternoon, Professor Chuyên.
Good afternoon.
Can I start now?
Yes. Cho cái slide, toàn cho cái biết cái slide của cái ông cô trẻ của thầy đây. Ở đâu á để nghe tiếng vang đó toàn điều chỉnh lại đi cái tiếng. Tiếng vang mà.
Dạ. Dạ tiếng vang phía thầy hả thầy?
Không, phía thầy có tiếng vang. Tắt hết đi.
Dạ tắt hết rồi thầy.
Hết rồi loa này. Ở đây có tiếng vang.
Có vang từ phía thầy hả thầy?
Tắt hết micro đi.
Dạ, vang lắm. Dạ.
Ok.
Dạ.
Tắt hết rồi. Kêu nó lên tắt hết micro ngoài đi đó. Tắt hết hệ thống ngoài đi. Ok.
Bằng tổ chức chiếu cái profile của thầy lên nhé.
Ok, rồi bắt đầu là giới thiệu sau cái profile của ông kia.
Ladies and gentlemen, thank you for joining the session Everythingabout Bladder on Fire. Today, I'm honored to introduce to all of you Professor Vulichian. He will be a chairman for this section. Professor Vulichian is Associate Professor of the Urology Department of Ho Chi Minh City Medical University. He former head of Urology Department at Bình Dương Hospital in Ho Chi Minh City, Vietnam. And he is president of Society of Endoscopy and Laparoscopy Urology of Vietnam. He also been a council member of the Urological Association of Asia, UAA, and SEAL. He had many local and international publications. And now I would like to invite Professor Vulichian as the chairman to start the session. Dear Professor Chien, the floor is yours. Thank you.
Thank you, organizer, for the kind introduction. Welcome to the GIBS HUNA section, joint section. It is the theme of our session is everything about bladder and fire. Now I would like
Mất tiếng rồi, mất tiếng rồi. No sound anymore. No sound anymore, Professor. Technical problem from Taman. Yeah.
okay. It's okay now.
It's okay. Thank you.
Okay. Thank you. Sorry for technical problem. I'd like to. I have the honor to introduce my co-chair, Dr. Rajesh Taneja. He is chairman of GIBS. He is a senior consultant advisor in orthopedic surgery in Indraprastha Apollo Hospital in New Delhi, India. He is also the chairman of the education committee of International Society for Study of Bladder Pain Syndrome. Dr. Taneja, please give a welcome speech and introduce GIBS for our Vietnamese college. Thank you.
Greetings from New Delhi. It is my proud privilege to introduce this complex topic of bladder pain syndrome and interstitial cystitis, as it is known in few parts of the world, to this August symposium of Ho Chi Minh Urology Nephrology Association and the Global Interstitial Cystitis Bladder Pain Society Symposium. This is first of its kind, and I welcome you all for this scientific bonanza that we are going to witness in some time. So during our training, we used to read that this disease may present as the end stage of bladder that has been made irritable by emotional disturbance, a pathway of discharge of unconscious hatred in women. So obviously, the scientists at that time thought that this was just in mind and not an organic disease of the bladder. And when we came into practice, we were thinking whether it really exists in our part of the world, has anybody seen it, or it is just a dumping diagnosis for the clinician. But one thing is sure, we needed to respect pain, and pain, is incessant in a bladder pain syndrome patient. So we gathered in 2016 in Mumbai and formed the first annual conference of the Global Interstitial Cystitis Bladder Pain Society. We had with us the gynecologists, the pain specialists, the physicians, and of course, the force behind GIBS, Mr. Vishal Jajodia, who happens to be an entrepreneur. Without his backing, GIBS couldn't have moved forward from there. In 2017, we circulated the first clinical guidelines of Bladder Pain Society, which would help patients to be treated by the clinicians, whether they were the medical physicians or they were the urologists or gynecologists. In 2008, we had the theme. We wanted to bring everybody on the horizon from various parts of the globe. And we were successful in getting people from Europe, from Japan. And this is the picture of the 2018 GIBS. In 2019, we extended our theme to Beyond Horizon, and we had research workers working for us and presenting their thesis in the last in-person GIBS that was held in 2019. In 2020, we had to be happy with the virtual GIBS. The theme was Conquering Bladder Pain with You, and this is one of the pictures. And in GIBS 2021, which was the 6th GIBS, we had the theme to educate, identify, and treat patients of this miserable disease. So by the end of 2021, we have the presence of GIBS faculty and participants coming from more than 35 countries from the globe. And this is just a map. We are looking forward to the annual GIBS in August 2022, which we aim to be having as a hybrid conference. And the proposed theme is Treat a Bladder, Save a Family. So as you all know, bladder pain syndrome is largely a clinical diagnosis. What we need is to spend time talking to the patient, which gives us the diagnosis itself. We, as you know, have this disease, which is actually treatable. It is not a taboo, and it is just a teamwork. We as urologists need to own up the responsibility to lead, because all these patients are finally funneled towards a urologist. The message that I want to give is that there has to be a right balance of high index of suspicion while preventing overdiagnosis. Your eyes will see what your mind knows, but at the same time, if you have a hammer in your hand, everything looks like a nail. So we need to prevent this bit. Thank you very much, and I now welcome you to the scientific bonanza of the first GIBS and HUNA Association Symposium. Thank you.
Thank you, Dr. Taneja, for the welcome speech. Please give me the introduction for the first speaker, Dr. Mỹ Nhi. Okay, we have 5 speakers today. So I would like to introduce the first speaker, Dr. Nguyễn Bá Mỹ Nhi. She is a very famous obstetrician and gynecologist. He's a former director of the New Hospital at Ho Chi Minh City. He's director of Hospital Gynecological Center at Taman General, Ho Chi Minh City. She is now president of Ho Chi Minh City Association of Midwives. And she was also a vice president of Ho Chi Minh City Association of Perineology, member of Vietnam Association of Surgery and Endolaparoscopy, and also the member of Vietnam Association of Gynecology and Obstetrics. Welcome, Dr. Nguyễn Bá Mỹ Nhi. Please give your speech. Time is yours. Thank you.
Yeah. Thank you. Ladies and gentlemen, I am a Dr. Nguyễn Bá Mỹ Nhi. I came from the center of the OB-GYN, Taman General Ho Chi Minh City Hospital, Vietnam. Today, I'm very happy to present the topic, the OAB in the gynecologist perspective. And you know, the overactive bladder syndrome, or the OAB, follow the International Continence Society definition, is a urinary urgency usually accompanied by the increased daytime frequency and or the nocturia with the urinary incontinence. We can call the OAB wet or without OAB dry in the absence of the urinary tract infection or other detective disease. You can see here a urinary urgency plus a daytime frequency and or nocturia, plus or no urinary incontinence and no UIT or the offer detectable disease. There are some terminology that form the current ICS terminology. The first, urgency, that means the complaint of the sudden compelling desire to pass urine, which is difficult to defer. Increase the daytime frequency, that means the complaint that voiding occur more frequently during the working hour than the previously deemed normal by the individual or the caregiver. Nocturia, the number of time urine is passed during the main sleep period. Having worked to pass urine for the first time, the urination must be followed by the sleep or the intention to sleep. And urinary incontinence, that means the complaint of the involuntary loss of urine. And subtype of the OAB definition according to the ICS, OAB wet, that means the with the urinary incontinence, and OAB dry without urinary incontinence. You can see here a prevalence of the OAB for men. Dry OAB is higher than the OAB wet, but in the women, the wet OAB is higher than dry OAB. While these subtypes are commonly used in research, they do not adequately represent the heterogeneity and the clinical spectrum of the OAB. And the prevalence of OAB in Asia, you can see here the prevalence of OAB increases with age from the 40 to the 44 years old, near the 11%, but more than 60 years old, near the 28%. And prevalence of the condition, for example, neurological disease, diabetes, were associated with a significantly increased prevalence of OAB and increasing symptom severity associated with significantly lower patient perspective of the bladder condition response and the lower sexual quality of life in both of men and the women. And here in Vietnam, we have a study from the Hanoi Medical University, the 2016, by the Nguyễn Thị Nguyễn, Đỗ Đào Vũ, and Nguyễn Đăng Vững. OAB, the frequency, you can see here the wet OAB is louder than the dry OAB. And OIB, there are many impact of the patient quality of life. The first is psychological emotion. The inpatient having the OIB symptom, 32% reported feeling depressed, and the 28% reported feeling very stressed. And you can see OIB on the emotional well-being. OIB with the incontinence is higher than the OIB without the incontinence. And OIB patient also report a greater level of the anxiety and the embarrassment or shame. And for the social impact of the social relationship, the sexual quality of life, symptom of incontinence significantly affect the ability of the patient to feel comfortable in the social situation. And family and friends of OIB patient reported reduction in socially activity and consequent decline in the amount of the quality time spent together. Impact of the OIB on the patient of life concern economic of workplace. In United States, the annual directly cost for the diagnostic test, vision visit, treatment procedure, and medication, etc., were over more than 12 USD the billion. And whereas indirect cost of the OIB, loss of the work productivity, time off work, inability to maintain employment, were reportedly more than 800 USD million annually. You can see here in the table, the impact of the OIB on the work productivity. And common patient coping behaviors to cope with the symptom of OIB. Many patients employ the elaborate behaviors to hide and manage symptoms. Use absorbent product, medication, restrict fluid intake, wear special clothing to conceal accidental urine loss, regular schedule for urination, and the bathroom mapping. And the American Urological Association, AUA, and the Society of the Urodynamic Female Pelvic Medicine and Urogenital Reconstruction, SUFU's OIB guideline for the diagnostic work of the first line, additional diagnostic process by the history, vision exam, urinalysis, and then the optional additional diagnostic measure by the urine decanter, post-void resident assessment, bladder diary, and symptom questionnaire. And then the text for complicated or the refractory patient, for example, urodynamic cystoscopy, bladder ultrasound, and diagnostic renal, not used in the initial workup of the uncomplicated patient. And you can see here that we have the symptom questionnaire for detecting the OIB, and bladder diary, which concern amount of the liquid introduced, aberration number of the urination time, total urine volume, natural urine volume, level of the UUI, and urinary incontinence. We can see here the bladder session scale from the 0 to 4, and urinary incontinence scaled by class 1, the summer throat, class 2, the moderate loss, wet underwear, and class 3, the severe loss, wet outer bladder. And all the guidelines for the treatment of the female and the male with the urinary incontinence. The first conservative treatment, symptomatic treatment, constipation treatment, prevention, medicine combination, and lifestyle change, caffeine reduction, drink change, moderate physical activity, weight loss, smoking cessation, and behavioral change therapy and tactic. Avoid being rushed for the patient with the UI. Bladder training, that means that the first try. pelvic floor muscle training in the female patient, no matter electromechanical stimulation and no magnetic stimulation for the UI or the sample or OAB. Medicine for OAB, UUI, the treatment, muscarinic or the mirabegron. And patient with OAB will benefit from non-pharmacological measure prior to starting antimuscarinic therapy. The guideline, the treatment guideline from the AUA and the SUFUs in 2019, the first line behavioral therapy for all patients may be combined with the pharmacologic therapy. Second line, the pharmacologic, the agent beta-adrenergic receptor agonist and antimuscarinic. Those modification are switched to different medication if inadequate efficacy or poor tolerability. Combination therapy beta-adrenergic receptor agonist plus antimuscarinic if refractory to monotherapy. The third line, interstitial or the botulinum toxic A, peripheral tibial nerve stimulation, sacral nerve stimulation, and additional the treatment augmentation cystoplasty or the urinary diversion for severe refractory complicated the OAB patient. And you can see here the protocol additional treatment for UI in women from the Health Service Research KCE in the Belgium. And in the PU Hospital Euro Gynecological Unit, we have a treatment regime for the UI in the women treatment regime for UI in women with the pharmacology. For example, the tip of the medicine cause UI and the medicine for the SUI, straight urinary incontinence treatment, and medicine for the OAB treatment with the antimuscarinic, antispasmodic agent, botulinum toxic A, and desmopressin. And for the behavior of the change, what? Conservative treatment without the medicine, lifestyle change, weight loss, and exercise, dietary change, bowel regulation, etc. Smoking cessation, bladder exercise, pelvic floor exercise. And mechanism of action for antimuscarinic if used. We have two mechanisms. Mechanism one, antimuscarinic inhibit the parasympathetic contraction of the detrusor by blocking cholinergic muscarinic receptor. And mechanism two, antimuscarinic inhibit the afferent nerve activity at the urothelial sensor receptor. That means affect the detrusor smooth muscle. And you can see here, antimuscarinic affected the bladder salivary gland selectivity ratio. Solifenacin with the bladder 0.023 and salivary gland 0.15 and bladder salivary gland selectivity ratio of antimuscarinic the 6.5. And all the 2021 management of the non-neurologic, the female lower urinary tract syndrome recommendation, long-term anticholinergic treatment should be used with caution in elderly women, especially those who are at risk of or have a pre-existing cognitive dysfunction, and strength rating is strong. Assess anticholinergic burden and the associated comorbidity in the patient being considered for the anticholinergic therapy for the OIB. Strength rating is weak. And management of the non-neurologic female LUTS recommendation offer mirabegron as an alternative to anticholinergic to women with the overactive bladder who failed conservative treatment with the strength rating is strong. And summary for my topic, ORB impact on the first ORB impact on the quality of life the patient, common in the women and increasingly concerned by gynecologists along with other disease and the pelvic floor disease. The second, avoid omission and misdiagnostic. The third, behavioral therapy is an important factor in the initial ORB. And medical treatment play a critical role in the ORB treatment. And of course, is better if we follow the guideline for the treatment ORB. My topic here. Thank you so much for listening, and keep your smile try forever. Thank you again.
Just like Pandey.
Yes, it was wonderful. Congratulations on this wonderful talk, Professor Nguyễn Bá Mỹ.
Cho profile tiếp theo đi em ơi.
Yeah, now I would like to invite my dear friend, Dr. Sanjay Pandey, who happens to be secretary in this organization. He works as head of the department, Urology and Gender Reassignment and Renal Transplant Department in a multi-speciality, in a tertiary care center, which is a very prominent center in our country, located in Mumbai. So I would like to invite Dr. Sanjay Pandey to talk about diagnosis of interstitial cystitis bladder pain society. You know, you have to have a high index of suspicion, and making a diagnosis is like making a hole in air. But I'm sure Dr. Sanjay Pandey is going to tell it very simply in very simple words. Over to you. I present to you Dr. Sanjay Pandey from Mumbai.
Very good afternoon to all colleague delegates. Thank you for inviting GIBS and us in this wonderful HUNA 18th, the Conference of Urologists of Vietnam. The topic given to me, clinical diagnosis of interstitial cystitis bladder pain syndrome, is an important topic to take this subject forward. I carry greetings from Mumbai, from the Kokila Bendhurbai Ambani Hospital, where we carry a motto, every life matters, which means all of us in the audience today are attempting to improve the quality of life of individuals. And in looking to do so, we know that while the world is at crossroads and the global threat is not over yet, there's another kind of a crossroads which these patients go through. We have a difficulty of diagnosing the discomfort in the bladder pain syndrome or interstitial cystitis in the region of bladder and the pelvis, where a patient could describe it as a discomfort or as a pain or as a dyspareunia, issues which actually make it very difficult for the clinician because there are so many organs of overlap. There's so many diseases which could actually be happening in the pelvis and the perineal location. The individual who suffers from this disease, interstitial cystitis bladder pain syndrome, comes with umpteen aspects to be looked at. In other words, they complain of pain on bladder filling. They complain of urinary complaints of urgency, urge incontinence. They have gross frequency related to the pain and discomfort. They also could be going through this progression of the disease why there are flares which could be brought about by a UTI or by a stress. And because majority of the patients are women compared to men, there's always that agony as to whom to show it, because many of women across the country and the world, including Southeast Asia, still go and see their gynecologist. So while the patient is in stress, the family is in stress, the individuals who have a look at it as urologists finally in the end know that there is a progression of the disease happening around. To bring about a clinical diagnosis of a situation where the gag layer could be deficient, there could be changes happening in the bladder, there's always a dilemma in the disease. Friends, there's a challenge to diagnose a disease of that kind where there are so many overlapping features. Confusion happens therefore with various genitourinary, gynecological and pelvic floor disorders. Patients have already seen multiple doctors in different fraternities in different parts of the country. There are years of suffering, some for even more than a decade. That's hard to believe, but patients do continue to suffer. And that's where the dilemmas are huge. They've undergone sometimes surgery by learned colleagues in gynecology and urology in a hope to get a cure like a TURP or a hysterectomy. Sadly, there's lack of objective evidence in the entire evaluation and the therapy that they've got. And therefore, friends, patients across the world and in Asia continue to be in the agony of how to take it forward. As much as a clinician in the audience today, including us, to look at how do we take this patient in a juncture when they are in agony, which means that there is a huge amount of impact on the quality of life. While they suffer pain in the pelvis, pain in the perineum, pain in the lower aspect, they have got urinary symptoms of urgency, frequency, urge, incontinence. They will having a reduced quality of life, which is what brings about the crux of the matter. On one side, limitation on sexual intimacy, curtailed activities, sleep deprivation, getting up with pain at night, and reduced ability to continue the work, all brings about a diagnosis of pain. That kind of impact on the quality of life brings about a huge emotional impact for them at their workplace and in their homes. The fact that you have a disease for which there's no known cure in the past bring about a loss of faith in the medical system and doctors, because they were attempting to see doctors in various fraternities, feeling stigmatized and isolated. And finally, therefore, they have a tendency of depression and suicide rates across the world. While this is happening to them clinically, deep inside, there are changes happening in the vicious cycle where there is some kind of a bladder insult, which could be immunological, which could be chronic bacterial or chronic inflammatory, bringing about that insult where the urothelium or the epithelial layer may be undergoing a dysfunction. The potassium leak which happens into the interstitium, bringing about an activation of the C fibers and release of substance P, which causes the discomfort that happens when the bladder stretches to fill up even minimal, bringing about a mast cell activation and histamine release, and therefore more injury, and the vicious cycle goes on. The patient is going through it deep inside, silently and invisibly, while clinically there's a progression happening. Friends, isn't it a difficult and a unique disease that today we are challenged to clinically diagnose it? Presentations are quite variable. Sometimes it could be very vague symptoms at outset, whereas sometimes it could just be a flare and a massive outset of a disease. And we have, in our own understanding over decades of work, missed the entire board because we were treating them as if they were recurrent urinary tract infection, which actually was causing a flare. And many times in urological and urogynecological parlance, they've been treated as overactive bladder. The difficult and unique nature also is because of vast age group from 20s to 60s, with female preponderance ranging from 5 to 9:1, in a disease which is progressing and disabling for years to even decades. And now, finally, we understand there are modalities of evaluation and tiers of management. But friends, our entire foundation on the subject of clinical diagnosis was sadly without any past guidelines. We did not have that kind of a teamwork on a multidisciplinary aspect which we could have done, because the disease is one of overlap, and there was missing multimodal therapy, which is required to be at the outset of deciphering the components separately. Therefore, it was always difficult to define, diagnose, investigate, and treat certain individuals who were suffering in all locations. I told that men suffer lesser, but men could be incorrectly diagnosed as prostatitis and non-bacterial prostatitis. Therefore, let's watch out our men who are in prime of life and could be suffering, and we may miss it out as prostatitis. Early stages may be quite subtle, as I told, and there could be progression, and there could be basic treatment happening till a flare happens, which could be exacerbated by a UTI or by a stress. And one UTI could lead to a slippery slope where cultures get treated, symptoms worsen. Sometimes exacerbation happens with various aspects of changes in the menstrual cycle, and the symptoms worsen both on one side giving lack of rest, sleep, activities, other side the stress of the disease and not being able to diagnose. Patients also notice, which is a positive clinical point that comes out in the history during evaluation, is that coffee, alcohol, carbonated drinks, citrus fruits, tomatoes, and dark chocolates exacerbate symptoms. So we're trying to fit the jigsaw by identifying all these aspects in the history and the positivity. Diagnosis are therefore are symptoms of above lasting with chronicity without urinary tract infections. The clinical correlates on such diseases which have to be diagnosed with positivity to pick up something which is going on and on has to be a lot of aspects of history and physical examination. For example, frequency urgency symptoms are primarily bladder symptoms, could also be because of secondary pelvic spasm, and that suggests bladder component of the disease, which must be assessed with pelvic floor muscles. Therefore, we require that kind of our colleagues on the pain therapy and physiotherapy aspects. Dyspareunia could be because of bladder pain, because of vulval pathology, or a pelvic muscle spasm. And I still stress a point of good history and physical examination, which could distinguish between these aspects causing dyspareunia. Pelvic pain can be also because of bladder, vulval pathology, pelvic floor spasticity and endometriosis, and various organ crosstalks. Again, good history and good clinical examination. And then we are looking at the clinical attributes to diagnose a disease of dilemma. So let's look at what kind of patients we are aiming for when they actually come to our clinic. So all women, because women preponderant disease who visit your clinic, persons who have got pelvic pain, pressure or discomfort, those who have got that kind of an aspect, and could be the ones whom we are targeting to. But if they also have an add-on urinary complaints of urinary urgency, forced frequency and dysuria, then they could possibly be the target population who could be suffering from the disease, but because of umpteen aspects on somatology, they may not be able to inform us. Therefore, it's for us as clinicians, we hope to look at that group of a Venn diagram where we look at identifying the right patients with pelvic pain, pressure, discomfort, and urinary symptoms who could be thought about and could be taken from. Therefore, the considerations and diagnosis of bladder pain syndrome are to go back on Monday morning and look at the refractory patients that we on our gynecologists have treated and the new patients who come in. All those patients in the past who have been treated as recurrent UTI but did not get the relief, or chronic pelvic pain or exacerbated intraoral and perineal pain or pelvic pain syndrome and did not get the relief which we aimed for as a teamwork, possibly could be the refractory cases of interstitial cystitis bladder pain syndrome. Don't forget that we have had our overactive bladder treatment failures, and they actually were never overactive bladder, like never recurrent UTI. We need to revisit such refractory patients and look at why their treatment fails, and possibly we could be able to identify with positivity that this patient could be a case of bladder pain syndrome. Similarly, concurrent endometriosis and or failed medical treatment could also be a reason that we were treating endometriosis, whereas they could be coexistent of bladder pain syndrome. If we're looking at that aspect, we're looking at our new aspects arriving from Monday morning, where a patient walks in the prime of life between 20s to 60s, complains of urgency, frequency, pain, dyspareunia, given up sexual activity, complains of relief of urinary discomfort only by voiding, gives positive points towards picking up those which are aiming for. So therefore, GIBS as a society looked at the inclusive definition by the core committee and identifying patients by history, by clinical examination, moving to quickly identify them in their years of suffering that they had gone through. We define it as pain or discomfort in lower abdomen and or urogenital area of more than 3 months duration, adding to chronicity, which is worst on full bladder, along with one or more lower urinary tract irritative symptoms like the frequency, urgency, and nocturia, with or without standard stigmata on cystoscopy, provided other discernible pathology likely to cause the symptoms have been excluded. I'll come to those pathologies which we need to exclude. And therefore, we came up with best clinical practices in interstitial cystitis bladder pain syndrome in 2017, which happens to be the global latest guidelines that gives us safe clinical practices. And I hope that everybody in the audience should be having a copy of this to take it forward as a clinical activity. Because we are looking at an aspect of identifying these patients, we have to look at 4 such patients who will be presented to you on Monday morning to look at the refractoriness of these patients. Let's look at those patients who are going to come in, and let's get an idea about what could be a clinical diagnosis of such patients. Mrs. B is a 44-year-old journalist in Hanoi. She has got gross frequency of urination, both by day and by night. She complains of burning sensations in the lower zone, which is the region of the pelvis and the perineum. She has got dyspareunia. She also has got regular menstrual periods, but has been treated as recurrent UTI over the past 4 years with our colleagues in urology and gynecology, has got not much relief. She sees you for the first time in 48 hours on Monday morning. Remember, she did see her gynecologist during the flare-ups, which actually was treated as recurrent UTI. So you've got somebody very young in prime of life who's got all those symptoms, but has not got a therapy. Let's look at Miss K, a 29 years young girl who is single, a cinematographer, and lives in Ho Chi Minh City. She has gross, learned, and forced frequency for the last 3 years, which is gradually progressive. She's forced by lower abdominal discomfort to visit water closet more than 20 times a day. And she wakes up at 9 few times to pass with discomfort, not just with urinary symptoms, but with pain and discomfort. She passes every time a small amount. She has got irregular periods and a PCOD, and therefore sees her gynecologist, and her urine routine and cultures are normal. She's going to see you 2 days later. Remember, she sees her gynecologist. She is not a case of UTI. She may not have told her gynecologist, but she continues to live with an agony in the pelvis, which is all about progressive discomfort, more so when the bladder fills up and therefore she runs to the washroom. Let's look at a postmenopausal lady who complains of burning sensation in introitus. She is 54 years young, Mrs. L, and she comes from Da Nang. While she has got pain on full bladder, there's only some relief with emptying. There's been a progressive issue. She has got pain on traveling in motorbikes in the lumpy, bumpy roads of Da Nang. She describes this as painful urgency. She gave up her sexual activity completely, and she's being treated for endometriosis by her gynecologist. Could she be having a coexisting interstitial cystitis? Possibly. She has got no relief on a treatment of endometriosis till now. She hopes to get a relief on 10th January, Monday morning, 2 days from now, when she will see you. And finally, a patient who is only 22, as young student with Haiphong, who has commenced her whole complaints as a urinary tract infection with dysuria, fever, urgency, hematuria, all this entire single episode post-coital, which came 4 years ago. She has, from then onwards, described her pelvis on fire. Her menstrual periods are haywire. Her coitus is uncomfortable. She voids by day and by night. Her prematuration, pre-abdominal pelvic pain, which radiates to the region of the anus, to the groin, to the vagina, to the thighs, is all about giving her suffering. Aren't these patients quite refractory? Aren't these patients seeing clinicians already? She's going to demand her help at 11 a.m. on Monday morning, 2 days later. Friends, we're looking at symptoms of discomfort, heaviness, pressure, pain, all this going down out there and have different exacerbating factors. Somebody gets up with pain, somebody cannot hold urine, somebody has got pain while lumpy, bumpy roads actually attack them. They also have got urinary symptoms. So it's just not pain. A combination of these two going on a meandering fashion has troubled these individuals. And the pain is not in one location. It could be arising in the lower abdomen, perineum, vulva, clitoris, shaft of penis, inner thighs, lower back, anus. The organs and the organ crosstalks, the muscles, and the various organs in the pelvis could be giving it. Friends, where does this interstitial cystitis bladder pain syndrome begin? It could be probably a flare-up, as I told, but it could also be gradually growing up in the era of misdiagnosis of overactive bladder and recurrent UTI, or the diagnosis of past urethral syndrome, while mild to moderate to severe and advanced diseases gradually move forward in the disease contour. Normal bladder, which is lined by a bladder lumen and has the gag layer, which is the protective layer of the urothelium, could get disrupted with changes happening around. As a result of this gag layer going away and there is a defective urothelial barrier, there could be a pan-inflammation or pan-cystitis where the lamina propria and the lower layers get actually inflamed. That inflammation brings about irritation of the nerves, and an entire vicious cycle I did talk about a few slides ago continues to irritate the urothelium and depth of the suburothelial regions, which is in this region of pancystitis. This occasional quiescence and the flare-up could be something which needs to be diagnosed. The bottom line is we need to have a clinical diagnosis very strongly, which Gibbs and the definition empowers us to. We look at the history, look at the physical examination, but also look at the basic evaluation of a patient, because we want to rule out some aspects. We finally will look at advancements which are required to look at those patients who deserve to be looked at the outset. So for example, the 3-day voiding diary, which is a frequency volume chart, gives us a lot of idea as to what they're going through. We also have something called as food diary, which gives us an idea as patients avoid those kind of foods which cause flare. Friends, we're looking at ruling out a UTI or a recurrent UTI, and therefore a midstream and a clean cat specimen, looking at urine routines and cultures. And if there's a persistent pyuria with negative cultures, which we call as sterile pyuria, we need to rule out genitourinary tuberculosis in this part of the world, the Southeast Asia, or look at partially treated UTIs, and sometimes specific cultures required for microorganisms like ureaplasma and chlamydia. Friends, in the suspicion of urological malignancy or with persistent microscopic hematuria, sometimes it could be possibly a carcinoma in situ. We need a urinary cytology. Obviously, there has to be a practice which could be multimodal and multidisciplinary, and urological referrals of all this should happen, and cystoscopy and invasive requirements according to local protocols are required. Just deciphering all that clinical diagnostic evaluation, frequency volume chart of voiding diary is a very important aspect to look at. something we clinically could miss, but this differentiates a global polyuria from a small voided samples in a case of interstitial cystitis bladder pain syndrome, because the discomfort making the bladder a pancystitis issue, making the patient run again and again. Therefore, the patient voids multiple times compared to 5 to 7 times every day. To determine the severity of the storage symptoms, it can be used as for a positive reinforcement related to the behavioral and the pharmacological therapy as the patient comes back with frequency volume charts over the next few weeks to few months, where the behavioral therapy and the therapies for the bladder could help it. Friends, the baseline investigations beyond the basics are ultrasonography, looking at the bladder aspects, looking at the post-void residue, because many of them are in prime of life, who could be perimenopausal with high residual volume and leading to recurrent UTI as a concomitant issue. Symptom scores like pain scores, quality of life, clinical phenotyping are all required, because in a multidisciplinary teamwork, we need to look at empathy, work, identifying them and looking at the response to therapy as time goes by. Potassium sensitivity test, which was described in the past as an aggressive test, has been given up completely. It was all about looking at using potassium and identifying the sensitivity of already urothelium, which is actually wanting and probably has got the breach of the ganglions. Therefore, we look at Dr. Taneja's intracyclic anesthetic bladder challenge, where alkalinized lidocaine test, wherein still 10 to 20 ml of anesthetic mixture of 200 milligrams of lidocaine mixed with soda bicarb into an empty bladder, held for 10 to 15 minutes and then drained out, is a positive test where a patient feels relief. A relief of a patient who is going through all this could be something which we need to look into and probably help them out. Therefore, this test is an important positive test. Urodynamics is not routinely required. It could be required in patients who have got diffuse or overactivity, or those who have got issues with bladder dysfunction or pelvic floor dysfunction. Those patients could require a urodynamic study, which we need to wake up. Friends, we may not need to diagnose by biopsy, but potassium sensitivity test, which is a provocative test, a urodynamics, or a urinary biomarkers. These are all for different evaluations, and possibly all of them are not required directly to get into it. Biopsy could be ruling out during cystoscopy aspects of other pathologies, which is required so that there are no other pathologies exist like carcinoma in situ, eosinophilic cystitis, tuberculous cystitis, edematous pancystitis, and aspects we need to look into. Friends, this disease has always been a disease of exclusion and diagnosis of exclusion. European Society actually came up with a huge amount of differential diagnosis, which if I open up today in a short presentation, they are all this, which very closely correlate to the disease that we are looking into. Friends, while these diseases could be happening, there could be interstitial cystitis, bladder pain syndrome coexisting, or upper diseases may not be there. Therefore, as a clinician, it behoves that with good clinical history, evaluations on methodological lines helps us out. We never look at getting into depth of the evaluation invasively unless a patient comes with something as difficult as a symptomatology which is flared up. Cystoscopy could sometimes be required at the outset in a very flared up issue, or a disease patient with a very severe symptom. Something which we and the GIBS latest guidelines have looked into and looked at the evaluation as to how do we do a cystoscopy. And the role of cystoscopy in interstitial cystitis bladder pain syndrome is immense. In other words, there's a diagnostic, there's a therapeutic, there's a surveillance and prognostic requirement in such patients. For example, when we do a cystoscopy, we could find glomurulations, which are not a sine qua non, but the Hunner's group of lesions, which are those ulcerated pockets, which could be global phenomena that could show up with radiated vessels as on the left side upstairs. You look at these are quite a severe kind of disease compared to the non-Hunner's bladders where the cystoscopy could be completely normal. Patients could have glomurulations or petechial spots, which no one is taken as a diagnostic of a disease. Anything which looks abnormal could be biopsy, because you need to rule out eosinophilic cystitis, carcinoma in situ, and other diseases like genitourinary tuberculosis which could happen. As I come to a close, I need to look at interstitial cystitis bladder pain syndrome is a teamwork. It's no more a taboo. Evaluation and stabilization is in lines with the pathology in the pelvis with organ crosstalks. We need to evaluate and stabilize parallel. We need to identify the confounding factors and not to mess out diagnosis, which could be others like genitourinary tuberculosis and carcinoma in situ. We need to place measures at outset, identify and move forward in the evaluation, because long-lasting measures are the one which will give us the goal across this whole Asia-Pacific region of saving the bladder. While I welcome you all to GIBS 2022, open up the website called gibssociety.com and look at our next conference coming up on 27th and 28th of August 2022. We welcome all of you to this important and wonderful Congress. I summarize by saying that you are going to see your 4 patients on the first visit, which is today or Saturday, 2 days later, who are fitting somewhere into this. We are looking at pain, discomfort, and pressure on bladder filling, which is getting relieved by avoiding. The 4th frequency, discomfort, living a life on diapers, adjusting to ineffective treatment that has gone on to them is possibly not the way. The positive test with Dr. Taneja has actually advocated called the xylocaine sensitivity test is a positivity which in an office test could help you towards evaluating and giving us a chance to look at. So this is quite a conundrum where we need to wake up and finally treat them towards a management, which my friend Dr. Shivam would talk about in detail. Friends, as I come to a close, I salute all of you in this audience giving us a chance to talk on this cystitis, bladder pain syndrome, a difficult disease. If the treatment is delayed, the lives are lost and people continue to undergo sufferings. Thank you so much for this important presentation.
Thank you very much, Dr. Pandey, for the very interesting and informationful lecture. Now, I would like to introduce Dr. Professor Nguyễn Thị Bay. She is the Associate Professor at Traditional Medicine, University of Medicine, Pharmacy at Ho Chi Minh City, Vietnam. She is now President of Ho Chi Minh City Society of East-West Integrated Medicine. And she also the member of Vietnam Traditional Medicine Association, World Federation of Chinese Medicine Society. I would like to introduce our expert in traditional medicine because I'd like to introduce a new perspective of bladder pain, pelvic pain, and IC in point of view of traditional. Now, Dr. Professor Nguyễn Thị Bay, take your time.
Dear chairs and colleagues, as we all know, herbs have been used as medicine ever since humans existed on Earth. With the development of modern medicine based on clinical science, therapies for health care and treatment of disease take on the supporting role. Referred to as traditional medicine in some countries. Meanwhile, many countries, including Vietnamese, still use traditional medicine and modern medicine side by side in healthcare. Today, I'm very honored to talk about the role of traditional medicine in the management of chronic prostatitis and chronic pelvic pain in men. Here are the main parts of my talk. Ladies and gentlemen, according to the United States National Institute for Health, CP, chronic prostatitis, chronic pelvic pain syndrome, now we call CPP syndrome, is defined leukocyte in expresses prostatic secretions, post-prostate measures, urine or semen. According to Western medicine, the etiology, clinical symptoms such as pain, pain in the pelvis region, pain in lower abdomen, testicle, dyspareunia, genital itching, pysuria, hematuria, trouble urinating, dysuria, even erectile dysfunction. According to Eastern medicine, Tongue syndrome, Yang syndrome, Gowling swelling, Lyme disease, Pulin, Young Way syndrome. According to Western medicine, clinical symptoms. According to Western medicine, the etiology of CPBS is difficult to determine, but there are proposed mechanistic theories such as neurotransmitter imbalance, anatomical anomalies, or dysfunction of pelvic floor and supporting structures, psychological behavior factors, inflammation, infection, immunity, abnormality. According to Eastern medicine, the kidney unable to restore essence. The bladder function have not to control. Exotic dam heat delivery enters conception and penetrating vessel. In the long term, this condition subsequently damages 3 organs: spleen, liver, and kidney. According to Western medicine, the etiology of syndrome such as infection, intraprostatitis, urinary reflux, oxidative stress, neurotransmitter, abnormal hormone concentration, sexual intercourse, constitutional weakness. According to Eastern medicine, we have dam heat, internal dampness, emotion, pressure or depression, essence deficiency, internal heat, primary, secondary key deficiency. This pathophysiology, every summary. According to Western medicine, chronic pelvic syndrome begins with the tissue injury of the bladder and prostate caused by trauma, infection, allergy, or drugs. This form vicious circle of inflammation, bladder, neck, pelvic floor, spasm, and ischemia. Stress, depression, maladaptive, psychological response, gastroenteritis. Inflammation also causes further tissue damage. This slide shows the relationship between traditional medicine with the conventional medicine. In pathology of prostatitis, traditional medicine believes that all pathogen causing infection, such as bacteria, fungi, belong to external pathogenic factor, whereas internal damage, rage, or depression, high frequency of sexual, elderly, or constitution weakness. We are risk abnormal immunoreaction that may be lead to prostatitis. There are 4 syndromes in Eastern medicine which are divided into categories: excess syndrome and deficiency syndrome. In excess syndrome, we have to dam heat syndrome and quasi stagnation. The clinical symptoms of damaged heat syndrome are testicular or low back pain, polyuria with or without hematuria, fistulae, genital itching, dry throat, yellow greasy coating, tongue, hurried and sleepy pulse. With a cancer stagnation, prostatitis syndrome, tongue dark red with a purple, red spot, thin, white, and dry coating. Pulse is wiry, fine, and hurried. In deficiency syndrome, we have a yin deficiency heat syndrome and spleen kidney yang deficiency syndrome. Every syndrome, there are some, for example, yin deficiency heat syndrome, unwilling reaction, priapism, vertigo, insomnia, or hypersomnia, flushing, tongue go red with thin, little or no coating, pulse fine and hurried. With spleen kidney yang deficiency syndrome, there are low back pain, heavy fluid feeling in genital area, nocturia, frequently diarrhea, colon extremities, tongue pale and swollen with teeth marks, thin white coating, pulse is deep and fine. Traditional medicine treatment choice depend on the clinical syndrome, including acupuncture, herb medication, or both. In today's presentation, I will talk about herbal therapy. The treatment principle, general perspective, detailed consideration. There are three core principles in treating prostatitis. First, we should cool the heat, invigorate the qi, activate the blood circulation, remove the numbness, and relieve the pain. Second, keep an eye on three organs, spleen, liver, and kidney. Lastly, aiming to resolve concurrent signs and symptoms. These are review of Capodice 2005 about treatment option of chronic prostatitis, chronic pelvis pain syndrome, complementary alternative medicine. We call CAM option, include acupuncture, biofeedback, electrical stimulating thermotherapy, and herbal therapy. Recent review and meta-analysis unlock the potential of herbs when combined with the Western medicine to treat CP-CPP syndrome. A publication of Chen 2016 combined with Ning-Mi-Tai, traditional medicine, and levofloxacin, improve the response rate, overall symptom, NIS, CBSI, decrease interleukin-2, interleukin-6, no different at adverse event. According to Chen 2021, combination of traditional medicine and Western medicine, better effectiveness in symptom relief, and the score of NIS, CBSI, IIEF-5. And a more formula with there are some herbal formula is a treating each with the different composition and efficiency. For example, one EU with the formula decrease the TNF alpha, interleukin 1 beta, COX2, prostaglandin 2, prostaglandin E2, etc. With the XLQ formula of XLQ enhancing the activity of antioxidative enzyme, suppress the activation of NF-κB and P38 MAP signaling pathway. With the formula this side Y, 1075. Decrease the TNF alpha, interleukin 6 and interleukin 8. Fewer CFU in prostate tissue culture. The formula Conley-Tonge reduce inflammatory lesion and inflammatory cell infiltration, reduce serum level of TNF alpha. The formula of Conley inhibit inflammasome activation, oxidant stress, and autophagy. The formula of Jadu-Husserl decoction, regulation of NF and IKPA expression, and help the other. Certain herbs, for example, verben, clematis tenivula, rhizoma alismatis, curcuma longa, curcuma beetle, pepper. Radix astragalus, Plantagodepressa, Oppo, Hidiotis diffusa, Cortex cinnamomi, Cortex philodendri, Himalibris, Japonicus, etc. In summary, herbotherapy can combine with the Western. Herbotherapy can combine with the Western drugs. Herbotherapy can combine with the Western drugs in CPB syndrome. Based on clinical differentiation, we can apply proper treatment principle and herbal decoction to enhance recovery or response rate and relieve the symptom. The common mechanism approach is to cool heat, remove dampness, rectify qi and blood, which align with the Western medicine in some aspect, and anti-inflammatory, antioxidant, with or without antibiotic. Thank you for your attention.
Thank you very much. Hello. Thank you very much for this wonderful talk on the traditional medicine, which is actually very important because we forget that our ancient ancestors who have been having ancient medicines and knowledge were no less. Only problem is nowadays it is very difficult to standardize and to understand what they written and the interpretation of their literature. With this short note, I would now invite Dr. Shivam Proyadarshi, another colleague. He is professor and head of the Department of Urology at one of the largest medical colleges of India, situated in the state of Rajasthan, the city of color and valor. It's a pink city called Jaipur in India. So he's been having more than 25 years of the subject and is again a very special core committee member of the Global Interstitial Cystitis and Bladder Pain Society. I present to you Dr. Shivam Proyadarshi to talk about treatment of interstitial cystitis Bladder Pain Society. Dr. Shivam, please.
A very good evening to all of you. I bring greetings from Jaipur, the capital city of Rajasthan, which is the largest state of our country. I thank GIBS Society and the organizers of the 18th annual meeting of HUNA in Vietnam for having given me this opportunity to deliberate on the treatment of interstitial cystitis and bladder pain syndrome. I call this ICBPS as a disease of extremes. The patient may have extremely severe symptoms. It still remains extremely underdiagnosed. the treatment can range from one extreme to the other, that is alpha vitamin prescription to the omega of radical bladder substitution surgery. And sadly, there is still extreme confusion in the diagnosis as well as the treatment part of IC-BPS. So when the doctor tells the patient, congratulations, your endoscopy was negative and everything is perfectly all right, the poor patient is in a state of dilemma. He still has a lot of pain, his whole life is getting affected, and that he's in a state of fix whether his doctor actually is understanding his symptoms or not, or he is missing something, or is it purely a mental. So the challenges that we face in the treatment of IC-BPS, that is the management still remains controversial with more than 200 therapies available. And there are very few well-designed randomized controlled studies which can give conclusive evidence to the treatment. And many of these patients have syndromic varied manifestations which cannot be treated in a generalized manner. So the goal of therapy here should be realistic and mutually agreed upon between the patient and the physician. The main aim should be maximizing the symptomatic control and the quality of life while avoiding adverse events and treatment complications, and recognizing that there is no curative treatment for this condition. The management can vary from conservative therapy to diet manipulation, oral therapy, intravesical installations, cystoscopy, and lastly, surgery. So the treatment begins with the most conservative therapy in the form of patient education and counseling the patient regarding the disease, about its course, and the typical flares and remissions that this problem has. The patient should also be given a stress management, as stress can induce these flares, and then behavioral therapy, physiotherapy, analgesics, sex counseling, and dietary modification. The top 10 foods which need to be avoided in IC-BPS include coffee, tea, chocolate, carbonated beverages, alcohol, fruit juices, spices, artificial sweeteners, vitamin C, and highly allergenic foods. We usually advocate an elimination diet trial where the patient is instructed to avoid all foods on the list for a period varying from 1 week to 3 months, and then methodically reintroducing one item at a time with a waiting period of 3 days to identify the potential offender. The behavioral modification will include fluid diet management, the pelvic floor exercise with biofeedback mechanism, education reinforcement, and giving these patients a bladder diary and asking them to have timed voiding and disregarding the urge to void by different urge suppression strategies. Some of these patients may have high tone pelvic floor muscles, and physical therapy with or without biofeedback and soft tissue massage can help to release these myofascial bands and trigger points. Some of these patients may be helped by heat and cold therapy or transcutaneous electrical nerve stimulation. Personally, I believe that yoga can be very helpful in these patients because the asanas in different postures can help in progressive relaxation of tense and tender pelvic floor muscles. The breathing, centering, and awareness techniques offered in yoga practice can help to reduce the stress and consequently improve the function. And certain yoga poses and flows can help to calm down sympathetic nervous system, which plays an important role in the pathogenesis of interstitial cystitis. Some of these patients have sexual dysfunction and the couple requires counseling. They may be asked to have a warm bath to relax the pelvic floor muscles, urinate before and after sex, have cleanliness by both the partners to prevent any infection which can give rise to flares, use of non-irritating lubricants, and they can have pre-medication with painkillers around 20 to 30 minutes before sex. They may engage in mode of foreplay and limit the thrusting time, which is usually more painful. And they can acquire different positions, which can reduce the pain and symptoms. And some of these patients can have other innovative ways of sex, which doesn't involve penetrative sex and can maintain their sexual intimacy. The oral medications used are amitriptyline, which can be titrated from 10 to 100 milligram given at bedtime. And then analgesics, anti-inflammatory agents can be used. Some patients with allergic manifestations can be given hydroxyzine, 25 to 75 milligram. Patients with urinary symptoms can be given anticholinergics in the form of tolterodine, solifenacin, or mirabegron. And some of these patients who have neuropathic pain can be given gabapentin. Cimetidine, which is again an H2 receptor antagonist, can help also to allay the symptoms. Pentosan polysulfate, which is the only USA FDA approved drug, can be given in the dose of 100 milligram thrice daily for at least 3 to 6 months to show its efficacy. If the patient is refractory to all these oral medications, then as a last resort, immunosuppressive therapy, either in the form of cyclosporine or azathioprine, can be used in low doses. Some of the newer drugs which are in pipeline include quercetin, which is a bioflavonoid, IP751, which is again marijuana-derived analgesic, and MN001. And then we have a tanezumab, which is a monoclonal antibody with anti-nerve growth factor. The next step is using intravesical agents, installations of chondroitin sulfate, sodium hyaluronate, or dimethyl sulfoxide, that is DMSO. And various authors have used various other cocktails, which include bupivacaine, lugnecone, triamcinolone, heparin, and antibiotics like gentamicin, which can be used either weekly or bi-weekly for 6 weeks, and they have usually a 50% objective response. Cystoscopy, though not essential in the diagnosis of IC-BPS, is usually done in these patients to segregate them into a Hunner's lesion and a non-Hunner's lesion. It also helps to objectively evaluate the bladder capacity of these patients. And it also helps to rule out other lesions like bladder carcinoma or carcinoma in situ. During cystoscopy, therapeutic hydrodistension can be made by gravity filling of the bladder at 80 centimeter of water pressure, and then decompressing the bladder and refilling it and keeping it hydrodistended for around 2 to 3 minutes, which will help to show the stigmata of IC-BPS. If we find a Hunner's lesion, then it needs to be fulgurated either with electrocautery or laser, or a resection can be done. Some of clinicians would do an intralesional triamcinolone injection of these lesions. So electrocautery can be done with Rohrball electrode for these Hunner's lesion in patients with IC-BPS. The other therapies include cyclosporine, azathioprine, and tacrolimus, which are reserved for severe patients who are refractory to other treatment options. Botox can also be used. Botox A is used with 100 to 200 units doses and given at multiple sites throughout the bladder, and which helps to block the sensory nerves and which transmits pain and causes spasticity and inflammation. Sacral neuromodulation is another mode of therapy which will disrupt the afferent inputs to the bladder. And usually we will do a trial with the electrode put into the sacral nerve. And if it is efficacious, then we will implant this interstim device into the subcutaneous tissue, which will help in improving the symptoms. Surgery is usually the last resort, which includes either bladder augmentation, urinary diversion, or cystectomy. many of these patients have a trigonal disease. So supratrigonal cystectomy with augmentation is usually not preferred, and we prefer doing a total cystectomy with orthotopic neobladder or ileal conduit formation. ICBPS is a chronic disease, so it affects the patient and their families, which need to be informed about the treatment and coping strategies. So the patient support groups can play an important role here and help the patients. And it can be a step forward in learning patients how to cope with this problem. There are various other emerging therapies like hyperbaric oxygen, PD5 inhibitors, N-acetylcysteine, monoclonal antibodies, intravesical liposomes, adelmidrol, tacrolimus, transcranial magnetic stimulation, adalimumab, Botox, which is injected in liver and eye muscle. So this is the algorithm we usually follow if a patient comes with the symptoms of pain, frequency, urgency, and nocturia. We evaluate these patients with history, physical examination, and avoiding diary, urine routine examination, and ultrasound of abdomen and pelvis, and divide these patients into two distinct groups. One is an uncomplicated, unequivocal ICBPS case, and the other is an equivocal ICBPS case, which needs further investigation to rule out other problems. Like if the patient has a pyuria, we need to do a urine culture. If he's a sterile pyuria, we need to do an AFB culture to rule out tubercular cystitis. If it is hematuria, then we need to do urine cytology. If the patient suggests endometriosis, then need to do laparoscopy or imaging study. If the patient has a voiding dysfunction, then we need to do a urodynamic study. And if it is an uncomplicated ICBPS, then we do cystoscopy as a primary investigation, which will help us to rule out other causes of these symptoms, and will also help to segregate ICBPS into the two categories, Hunner's IC and non-Hunner's IC. Hunner's IC typically requires a therapeutic hydrodistension along with fulguration and resection, and will also be followed by conservative therapy along with pharmacotherapy, IV installation, and pain management. Many of these patients may require later Botox, cyclosporine, or neuromodulation. And if these patients ends up ultimately in an end-stage bladder disease, then they may require augmentation, cystoplasty, and cystectomy. And non-Hunner's BPS are often associated with fibromyalgia, allergies, IBS, migraine, and other symptoms. And the further treatment is based on the symptom phenotype, degree of quality of life impairment, the availability of that treatment, and the adverse event profile. So if the patient has a urinary predominant symptom, then we need to do bladder training, anticholinergics, and intravesical agents. If it is psychosocial, then we need to manage the stress and give them psychosocial support. If it is bladder specific, then we need to give them amitriptyline or pentosan polysulfate. Similarly, infectious disease requires antimicrobials. Neurologic problems will require gabapentin or hydroxyzine. And if there is high tone pelvic floor muscles, may require physiotherapy. So the treatment principle is basically from most to least conservative. Multiple simultaneous treatments may be considered in the best interest of the patients, and ineffective treatments should be stopped. Pain management should be considered throughout the course of therapy with the goal of maximizing function and minimizing other side effects. And diagnosis should be reconsidered if no improvement occurs within a meaningful time frame. So to conclude, treatment of ICBPS is still challenging. As the symptoms are varied, a method of phenotyping needs to be developed for proper management. Amitriptyline and pentosan polysulfate are the oral drugs. Long-term use of antibiotics and steroids are not recommended. In resistant severe cases, immunosuppressants like cyclosporine or azathioprine may be used. Future approach lies in a better understanding of the etiology of the various phenotypes, as well as the discovery and validation of biomarkers for the diagnosis. It is a chronic disease which requires a long-term healthcare plan. So millions of these patients suffer but there are very few clinicians who actually understand this problem. So we as a clinician need to be proactive in mitigating their suffering. So thank you. Thanks for your patient listening.
Thank you very much, Dr. Proyadarshi. Your lecture will help us a lot in the management of bladder pain and IC. Thank you very much again. So now I would like to introduce the last speaker. During my practice, I found that in our acupuncture practice, we found some point of acupuncture that is similar to tibial exciting. So I would like to invite one of the experts of acupuncture in our society to present this topic. I introduce Dr. Nguyễn Văn Đàn. He is the Vice Dean of Faculty Traditional Medicine of University of Medicine Pharmacy at Ho Chi Minh City. He is also the head of the Department of Traditional Medicine at Thống Nhất Hospital, Ho Chi Minh City, Vietnam. He is a member of Vietnam Oriental Traditional Medicine Association, World Federation of Chinese Medicine Society, and he was the author in Traditional Medicine, Acupuncture National and International Journal. So, ladies and gentlemen, I introduce Dr. Nguyễn Văn Đàn, please.
Dear Chairman of the delegation and colleagues, I am honored to participate in today's session with the topic acupuncture for the treatment of interstitial cystitis symptoms, with content of 4 parts as follows. Starting from different points of view about the human body, the trend of combining traditional medicine and Western medicine, taking power of each other, is a trend that is very noticeable today. This combination has to show many mankind's health problems. According to the WHO Global Atlas of Traditional, Complementary and Alternative Medicine report in 2019, 65 to 80% of the world healthcare practice involves the use of traditional medicine. This shows that the trend of using traditional medicine is rising day by day, lead the acupuncture. These are the important points about IC according to Western medicine and traditional medicine. For Western medicine, IC is a chronic non-bacterial inflammatory hemorrhagic disease of the bladder wall. The symptoms are urinary frequency, urgency, and usually pain. The diagnosis of IC is often a long and complex process and involves inclusion of other bladder disorders, which may give rise to similar symptoms. Meanwhile, traditional medicine classifies IC as a disease cellular. Diagnosis based on 4 examination, pattern identification, have a mixed pattern. This is full or empty heat, damage or deficiency of the spleen and or kidney. Generally, the spleen kidney is considered of vital importance in IC. There are many traditional medicine patterns associated with IC. This is important in clinical practice. The traditional medicine doctor will diagnostic TM pattern and then treatment by growth or non-growth technique. Application of acupuncture in the treatment of IC with the general principle regulating the flow of Qi and blood energy in the meridian system, combine selecting acupoints to directly treat the symptom of IC, with treatment directed at underlying pattern of disharmony. To relieve pain, we use bladder meridian acupoints such as bladder 63. This is a secret point on the bladder channel for very acute painful attacks. Or we use bladder 32, bladder 33, bladder 34 acupoint. Especially in case with the lumbar pain, we use the PL 22, PL 23, and PL 25. In some specific case, if patient have perineal pain and pain in the lower back, we use DU1 acupoint. If patient have pain of the urethra, we use level 4 acupoint. Or if patient have pain and burning of urination, we use the kidney 5 acupoint. And then to treat underlying pattern, in case tonify chi and plus and strengthen the spleen, we use spleen 6 or stomas 36. Tonify kidney chi, kidney yin and kidney yang, we use kidney 3 or BL 25. Tonify the bladder, UPL 64 acupoint. Resolve damage, relief dysuria, and alleviate pain in the external region. Use the SP9. Control reckless movement of hot blood and treat the hematuria. Use spleen 10. Smooth the liver chi or resolve stagnation. Use the liver 3. Clear heat and damage from the liver channel in the genital region and alleviate the pain of the vulvodynia. Use the liver 8. Calm the mind and pacify the spirit. Use DU 20, PC6, and spleen 4 acupoint. The next slide, one of the important non-rush techniques used in the treatment of IC is the electrical tibial nerve stimulation. When stimulating the posterior tibial nerve, will also stimulate the L4 to S3 nerve, affecting the bladder and the pelvic floor. The location of the stimulation electrode placement coincides with the spleen 6. Spleen 6 is a point, a crossing point of the channel of spleen, liver, and kidney meridian, which is used to treat lower abdominal organ disease, have urology, gynecology, and genital system disorder according to traditional medicine. Thus, it saw the combination of the traditional medicine and modern Western medicine in electrical tibial nerve stimulation techniques. The picture shows the mechanism of acupoint from the neurological point of view. Example, we use a BL 33 or BL 34 when stimulated is will stimulate surgical and prudential and twist the pelvic of bladder. In my department, we use for acupuncture methods, traditional manual acupuncture plus distribution or electro acupuncture or ear acupuncture or crest and petting acupuncture. This is the picture for acupuncture methods. about clinical evidence. The effect of acupuncture on urination control and decreasing IC symptoms, especially urgency and pain, can be explained by suppressing bladder activity onto the ferring profiles of bladder activity neuron in and around parenchymal nucleus via GABAergic system mechanism, inhibiting the sensory efferent nerve of the bladder, parasympathetic nerve activation, and regulation of autonomous nerve system balance, inhibiting capsaicin sensitive C fiber activation, preventing the transmission of pain impulse to brain over spinal cord, this is a study acupuncture for the treatment of bladder pain, urinary frequency, and urgency caused by IC by Honeyshaw et al. With the 10 patients. Show acupuncture into bilateral BL 33 acupoints with manual for 10 minutes. The treatment was repeated 1 a week for 4 weeks for the initial treatment. Result: acupuncture have improved the clinical symptoms of urinary frequency and urgency and quality of life scores, accompanied with increase of bladder capacity as well as with possible inhibition of the sensitivity of C fiber dysfunction. The second study, success of acupuncture in the treatment of painful bladder syndrome IC with the 15 patients with IC who had failed to respond to therapy and who were referred for acupuncture. This result acupuncture was successful in 100% of patients in terms of improving symptoms and 86% failed an improvement in quality of life. And the third study, effectiveness of acupuncture and moxibustion therapy for the treatment of refractory IC. This study have 8 female patients with refractory interstitial cystitis. Moxa needle was applied to shear in bladder meridian 32 acupoint and 34 acupoint, and electroacupuncture were performed on 33rd in bladder meridian at 3 hex for 20 minutes 1 a week. This result, acupuncture and moxibustion result in improvement in 38% of the patient with refractory IC, and repeated therapy makes the therapeutic effects. And for study, complete response to acupuncture therapy in female patients with refractory IC. This sample size is 10 refractory IC female patient receive 10 sessions of acupuncture twice a week. And conclusion, the result of study suggests that acupuncture appears to be an effective, useful, non-invasive method in IC patients. For my observation in my clinical at Thống Nhất Hospital and UMC at Ho Chi Minh City, from my clinical experience, acupuncture is effective in treating IC symptoms. I often use breast impacting acupuncture plus ear acupressure by vacaciasis because no need for daily acupuncture. Repeated after 4 weeks. The course includes 2, 4 to 5 times. However, IC can be difficult to treat and may require prolonged treatment, and one patient can repeat another section. This is especially the case when IC is completed with other diseases such as IPS or chronic fatigue syndrome or hypertension.
Thank you very much, Dr. Van Daan, for this wonderful talk on the acupuncture. This is really an interesting arena. I have been told by Professor Boulechon to conclude the session as we do not have time for the discussions. I would invite you all to join the upcoming national conference, that annual national conference of GIBS that we have, that is in August. And you can get in touch with any of us so that you can enjoy 2 days of interstitial cystitis bladder pain society discussions. And I'm sure those who are interested would be benefited. I again thank HUNA, Professor Boulechon, who have been very kind to have allowed me to co-chair this session. And I thank all the speakers, my colleagues, Dr. Sanjay, Dr. Shivam, and all the other speakers, and of course the delegates who have been very patiently listening to the proceedings. Thank you all, and bye for now, and looking forward to hear you and see you at the webinar in August 2022 with the theme Save a Bladder, Save a Family. We would know more about it. Thank you.
Thank you, Dr. Teresa. Thank you, Pandey. Thank you, Priji, Shakti. Thank you very much. Bye-bye.
Bye.
Rồi, xong. Ôi trời ơi.